So these are basic lectures because I don't know you. But without these basics, we are not going to be able to function effectively in the ICU. Can everybody hear me? Yes, no? Okay. So last lecture we discussed that as critical care providers, our main job is to deliver oxygen to tissues just enough so that the patient survives while they recover from their critical care illness. And we also discussed that the most easy and effective way of figuring out if you are delivering enough oxygen to the tissues is mental status, urine output, and skin mottling, capillary refill, stuff like that. But if you are in doubt, you can always just check the oxygen extraction ratio to see whether you are providing enough delivery of oxygen, DO2, for the patient's VO2, whatever it might be. And we also discussed that blood pressure does not really matter as far as cardiac output is concerned, but you need a certain amount of blood pressure to perfuse tissues, and usually that blood pressure lies somewhere between 55 and 75 MAP, depending on what blood pressure you live on a daily basis. If I have to change the DO2 according to the formula, I can change the hemoglobin, limited to 7 to 9. Saturation can't go above 100. PEEP is limited. After some time, it starts decreasing my cardiac output. And therefore, the only thing without real limitations, I can always increase the cardiac output to get more DO2. And the cardiac output is stroke volume into heart rate. And the stroke volume depends on preload, contractility, and afterload. So today, we are talking about preload. It's fluid. These are cheap, these are effective, but they can harm. And I don't want anybody to treat fluid. You have to treat it like medication. It has side effects and it has its usefulness, and there is the right patient for the fluid. When I talk about giving fluids in the ICU, I'm not talking about maintenance fluids. I'm teaching you today how to use boluses to have a good effect on your patient. And basically, what you are trying to do with fluid boluses, you are trying to do preload management. Okay, that's what you are doing. So 3 questions. Everybody should be able to answer. Give me a number. If 100 patients come to your ICU in shock, how many are fluid responsive? An undifferentiated shock, 62% of it is septic, 15% of it is cardiogenic, 15% of it is hypovolemic, and 2% or something is obstructive. If you look at a normal ICU, surgical ICU, medical ICU, call it. How many out of 100? Give me a number. Okay. What about you? Fellows? So, I have been interested in fluids for a long time. And initially, when they were figuring out how do you distinguish between people who will benefit from a fluid bolus and people who won't, they were using pulmonary artery catheters, which is your gold standard for finding out if your cardiac output increased or not. And it seems that it is 50-50. Okay. Undifferentiated shock, most of them being septic shock in a normal ICU of any kind, 50% of the people will be volume responsive and 50% won't. And what is the definition of a volume responsiveness? If I give you a fluid bolus of around 500 cc over 10 to 15 minutes, you will increase your cardiac output by greater or equal to 10%, is the usual, give or take, definition of volume responsiveness. Because if I give you a fluid bolus and you don't increase your cardiac output, the fluid is harming you because it will end up somewhere.
Is that 10% across all types of ICU patients or specific like septic?
That's the definition. Cardiac output, it goes from 15% to 5%. The bolus goes from 350 cc to 1000. and the time goes from 10 to 30 minutes. But if you look at all the studies and you come to like, what's the median here, volume responsiveness, variably defined, most people will agree that if you give a 500 cc bolus over 10 to 15 minutes and you get a cardiac output response increase of greater than 10%, you are fluid responsive. Okay. So one of the things is, if you just look at one study, okay, you can have any position in medicine and say this study supports me, and another person might bring another study and tell you just the opposite. Okay. So when you are making a medical decision, it's like, oh, grandma, you have calculated based on a 60,000 patient study. I have a calculator, and the chance of cancer is 83%. And grandma is doctor, do I have cancer or do I not? The chance is 83%. Doesn't mean anything. So in how do you convert what you call literature into the bed is that the nurse will ask you, should I give a fluid bolus or not? And that's not the time to quote studies. You have to say fluid bolus, yes or no. And then she'll say, okay, fluid bolus, how much? How much should I put in? And you have to come up with a number, right? So when we are when I'm making any kind of presentation, and this presentation has been slightly changed since 2005 when I first made it, I will either look at all the studies I can get hands-on over the topic and then come to a conclusion, or if somebody has already done a systematic review or meta-analysis, I go for that. And in the systematic review and meta-analysis, I look at the methods of how they have chosen their studies, because garbage in, garbage out. Okay, so they have to be chosen properly, and then you can do conclusions. Okay, observational studies being the least, they tell you which study you should be doing, but they give you suggestions, but you don't really make decisions on that unless observational study is the only thing you have. And randomized controlled trials, I wait for a few because they can be life-changing, and then suddenly another trial comes out which is life-changing too, but exactly the opposite of what the first trial was. Okay, so 50% volume response. So the second question is, because this is a fight that has been going on since I was a kid. Who's the fluid conservative? Here, raise your hand. Okay, good. And who's the fluid liberal? Very good, right? So you'll find people on different aisles. I'm not a liberal, I'm not a conservative. I make up my mind depending on what I'm dealing with. And I like Trump, but I'm not a conservative or a liberal. Okay? Depending on what you're asking about. I can be very liberal on some things and very conservative on the others. But people usually choose a side, and fights can be terrible. Question number 3. You have a monitor. Give me one value that you are looking at which informs you the most, and you get just one, about a patient's cardiac output or shock state.
End-tidal CO2.
End-tidal CO2, what about you?
End-tidal CO2.
CO2.
Cardiac index.
I don't know if cardiac index is here on this monitor.
Oh.
And I don't know if end-tidal CO2 is present in all the monitors. But
No, that one.
pulse pressure. Pulse pressure. The poor man's Swan Ganz is pulse pressure, right? Because what happens is that before people actually go into shock, they are in a compensated shock state. By the time they are in shock, it's getting late. Okay, you got to worry about what you do. Because what happens is that blood pressure 120 by 80, the 120 is determined by stroke volume, and the 80 is determined by SVR, okay, vascular resistance, right? So if you have a cardiogenic shock, what will happen? Your stroke volume will decrease, so the top number will decrease. And then what will you do in response to maintain your blood pressure? You will increase the systemic vascular resistance, so the bottom number will increase. So then you get something like 100/85. Okay, low pulse pressure, and the difference of the pulse pressure is less than the diastole. We are looking at possible cardiogenic or hypovolemic low output shock. If you are vasodilating, what will happen? Your SVR will decrease, bottom number becomes 35. In response, in the beginning, you increase your stroke volume. Now you're looking at 100/35. What's the difference? 65. Is it greater than the diastolic pressure? Yes, it is. Most likely you are looking at vasodilatory shock. So if I look at something, I look at pulse pressure and I see is the top number a problem or a bottom number a problem to guide me, and then we get more precise. Okay. So coming back, this is a real story. I was very new here, and there was a patient who had acute lung injury, and the patient was on 15 of Levoped, and the patient creatinine had bumped up to 1.7 something, and they were giving Lasix. So I asked, what are you doing? And this person who responded said, don't you know the FACT trial came out in 2006? Don't you know that? How stupid are you? Right? So first of all, when you quote a study, quote it completely. In the FACT trial, if you were on Levoped, you had to be off Levoped for 12 hours before you got Lasix. In the FACT trial, if your creatinine bumped by 0.3, you were not given Lasix. And more than that, when you actually look at the FACT trial, it seems that nobody was getting diuresed. The people, all of them, including the treatment arm, did get fluids when they needed. Except that when they got better with their blood pressure and all that stuff, the fluid got taken off. And at about day 3, they were fluid even. And at about day 6, minus 300 cc's was their cumulative fluid balance. Now you take this study, okay, and you say that I'm going to diurese patients on ARDS. That's not what the study shows. It never showed that. Plus the reason that we never gave any consideration to this study, 2006 or whatever, because they were using CVP to guide fluid balance. And in 2002, we already knew that CVP is full of crap. It doesn't tell you about cardiac output, fluid responsiveness, nothing, right? So you take a study, you have to go to the deep dive of it. Because if you see the conclusion from this study is, don't give too much fluid to ARDS patients. Now you take that conclusion and what your human mind will do is say diurese patients. That's not what the study says, okay? So any study that is quoted, you need to go to the bottom. I'll give you more example. I make up a study. 5 ml tidal volume is better than 7 ml tidal volume. And the conclusion is that the people in the 5 ml tidal volume arm did better. But then you go to the supplementary data and you realize that the 5 ml arm never really reached 5 cc per kg. They were at 7. And the 7 arm, they never could get down more than 9. Double triggering, respiratory rate high, because they have like, oh, if this happens, you can increase the tidal volume, right? So the conclusion that you get in the paper versus your real conclusion can be way different if you go into the supplemental literature associated with the study. Okay, but this is all how it started, the conservative fluid movement. Yes, in the fluid liberal arm, which got about 7 liters, there was less shock. So if you give fluid, if you are fluid liberal, you will realize you use less Levoped for less time. So your patients might go out of the ICU earlier. But if you give too much fluid, then they will be on the vent, they won't be on the pressor, and then you are in trouble because they are still in the ICU, and I just want my ICU empty if possible. Okay? But no difference in kidney injury, because if you are fluid conservative, you'll have more need for dialysis because you have renal failure, and if you are fluid liberal, you'll have more need for dialysis because you want to take out volume. Okay, no difference in mortality. All right, so not a very helpful trial. Then came 3 trials, one after the other, huge trials across continents, teaching hospitals, rural hospitals, you name it, very well randomized. Arise with the process, arise with the promise of due process. That's how I remember them. Arise, promise, process. Okay, good. They were about septic shock, randomized within 3 hours, and then they either followed Rivers et al. Protocol to the hilt, or you just do whatever you think is right for the patient. Standard arm versus EGTT. Rivers et al. Had taken sepsis mortality from 46 to 30%. And these three trials were at 18% mortality in established septic shock. It was a life-changing moment. All it proved is that standard care and EGTT care is the same, so you don't need to put what you call central venous lines in everybody. You don't need to have continuous SCVO2 monitoring. You don't need to have dobutamine and a hemoglobin of 9 in people. So you can do less and achieve the same results. But I was more interested in, that's a really good mortality. So how much fluid were these guys using? Because I would like to follow that protocol. In the ER before randomization, they had already got 2 liters of fluid. In the first 6 hours after randomization, they got about 2 to 3 liters more. And in the 6 to 72 hours, these guys got another 4 liters. We are looking at volumes that we don't give now. This was definitely a fluid liberal strategy. And you think it just happened with this one? The ARISE investigators, same thing. 2 liters, 2.5 liters before. About 2 liters within the first 6 hours. 4 liters between 6, and that's a lot of fluid. But their mortality was 18%. Okay? So these trials did not tell us that Rivers and et al. Were not knowing what they are doing. It just said that if you just use your common sense, capillary leaflet, knee modeling, lactate, blood pressure, urine output, mental status, you will achieve the same without spending so much time and money. I get that. But they were using a hell lot of fluid, all of them. Okay? A lot of fluid. So that sort of goes, I don't know. Then in 2022 and 2023, so what happened between 2015 when the 3 studies came out and now a lot of observational studies saying that if you give fluid, that is bad. You should not give fluid. You should not give fluid. But these are randomized studies. The first one, 1,554 patients, randomized in blocks of 6, good randomization across. What was the difference? If I am fluid liberal, I will give you fluid till I tank you up. And then, if you have knee mottling above the kneecap, okay, or lactate still greater than 4, or urine output less than 0.1, or a mean arterial pressure less than 50, I will give you pressors. The other guys, this is the fluid liberal. The fluid conservative guys say, I'll give you Levophed. And when I have maximized Levophed and maximized my pressure, and you have knee mottling above the kneecap, or 0.1 cc per kg per hour urine output, or lactate of 4, things that will scare us, right? We don't let people do that. Then I will give you fluid. And there was no difference in mortality, no difference in ventilator, no difference in renal failure, no difference in anything. Therefore, if today there is a board question, and you will hear it from the board people, since you don't believe me, I will make you hear it from the board people. Today, if there is a question, there is no difference, and they said that, apart against the observational studies that have come along, our randomized controlled trial has shown that there is absolutely no difference, and why should there be? Because over the years that we have been fighting, the liberal fluid people are like, maybe we should not give so much fluid. And the conservative fluid people are like, maybe we should give some fluid. And ultimately, the difference at randomization, at 6 hours, at 72 hours, at the end of hospitalization, the difference was never more than 2 liters between fluid liberal and fluid conservative. So that's what we get for the findings. There is no difference. So since I was never a conservative or a liberal, what I have been trying to say is, why don't you just be fluid appropriate? Give fluid to the people who need it, 50%, and give fluid to the people who don't need it. Because if you are fluid liberal and you know that 50% will be volume responders, those who don't need fluid will get harmed and those who need fluid will get help. And if you're a fluid conservative, those who didn't need fluid will be helped and those who needed fluid will be harmed. Why don't we give fluid to those who need it and don't give fluid to those who don't? Okay, and I will tell you exactly how I've been doing this for some time. So, when you are into preload management, basically what you are trying to do is you are trying to figure out where on the Frank-Starling curve does your patient lie. Okay? If they are lower on the curve, you give them fluid, they will increase their cardiac output. And if they are higher on the curve, you give them fluid, they don't increase their cardiac output. So where does the fluid go? In places you don't want it to go. And then we realize that there are two ventricles. Unlike the cardiology fellows, they think there is only one. There are actually two. Okay? And on top of that, they are interdependent. So I want to know not the right or the left, because it is possible, for example, in pulmonary embolism or in pulmonary hypertension or in right ventricular infarction, that the right ventricle is here, but the left ventricle is here. But where will you give fluids? Into the vein. And if the right ventricle is not working, it doesn't matter what the left ventricle does, the fluid will never reach there. In fact, the right ventricle will get more distended and the left ventricle will get more fluid responsive, except that there is no, that's where you use midrinone and butamine and stuff like that, but you have to keep that into account. The definitive test, how do you know what are you comparing these indices to? The definitive test is I give you a fluid bolus and I see whether your cardiac output increases or not. That's the definitive test. Except that by doing the test, if you're not fluid responsive, I've already harmed you. So in 1998 in pigs, somebody discovered that you actually get a fluid bolus with every breath on the ventilator. So in a ventilated patient, when I give you push in a breath, your venous return decreases. And 3 to 5 heartbeats later, that decreased venous return goes to the left ventricle. Okay? And your left ventricle stroke volume decreases. So when you give a breath, after a few beats, your pulse pressure, which is your indicator of your cardiac output, right? Because your SVR doesn't change minute to minute. So if the pulse pressure is changing, that means that I am having an increase or decrease in cardiac output. So if I tell you my blood pressure is 118/70, what's my cardiac output? You don't know. But if the pulse pressure has increased, likely my cardiac output has increased and the pulse pressure has decreased from whatever it is XYZ, it is lower. Okay? So pulse pressure variation, stroke volume variation, systolic pressure variation is a way to figure out with a 100% sensitivity and 93% specificity and a cutoff of 12%. But we don't do that 12%, 11%. You see, the more pulse pressure variation you have, 15%, you are becoming less sensitive, more specific. 10%, you are becoming very sensitive, not very specific. Okay? And then there is a gray zone in between where I don't really know. All right? So if you have a patient and you have an arterial line and you can see the pulse pressure variation with respirational breaths, and since we know from River et al. And these 3 studies, Arise, Promise, and Process, that whatever you do early, because all shock is reversible depending on the patient for a time X, after which you do whatever you want to. It's irreversible. Now you're talking ischemia, reperfusion, and all that stuff, right? So if you have intubated somebody just for 10 minutes, put them on a tidal volume of 8 cc per kg, okay? And at that time, I'm looking at the pulse pressure variation, systolic pressure variation, and I am giving them fluid because I'm using the fact that they are sedated and in sync with the ventilator. I'm giving them fluid before I do anything else. Okay? There are caveats. I will tell you the caveats. It's a very good way. And the cutoff being 12%, but you know that less than 10%, they are not fluid responsive, and greater than 15%, they are fluid responsive. In between, I have to use a little bit of my clinical judgment. Stroke volume variation, if you have an arterial line, you connect it. That's why so many people in the ICU have arterial line. And then they're not connected to the flow track. Use everything you got, okay? The cardiac output might not be reliable, but an increase is an increase and a decrease is a decrease, okay? And what we are looking at is not the cardiac output in general, but an increase in cardiac output in response to our fluid bolus. And fluid bolus is not 500 cc over 1 hour. We need to correct that, fellows. Get everybody 1 liter over an hour is just another night in with beer. But anyway, don't worry about it. If you don't have an arterial line and you are a really good ultrasonographer with steady hands, you can use carotid uptake. You can use, there is a probe that I guess somebody was wanting to sell to us, invasive, okay? You can use brachial artery, BTI, you can use LVOT, BTI, it's the same thing. If my dimension of the aortic valve is not going to change, so if the BTI increases, I have increase in stroke volume, okay? Not as reliable as PPV and SPV, but these are well-known and documented ways. And what we call AUC, area under the curve of 0.95 is a very, very good test. In people who meet the criteria, it will actually tell you whether you are fluid responsive or not. And if you are fluid responsive and you don't have right ventricular distension and you don't have pulmonary edema, give fluid. And if you have any of these side effects already, you are heading towards the ventilator, it doesn't matter what the PPV says. If my pulse pressure variation is 200, you're not going to give me a fluid bolus because I'm here giving you a lecture, right? So this is only for shock states, all right? Okay, so we are going to use clinical judgment. You have to be careful. Less reliable for tidal volume of 6. When you're doing this test, give some propofol, make sure that the patient is in sync with the ventilator. Tidal volume, make it 8 for a few minutes, it doesn't matter. Patient ventilator asynchrony will make it false negative. Heart rate, if it is 150, most likely you're not going to be able to see because the stroke volume is low. Why is the stroke volume low? Because your diastolic time and systolic time is low. Respiratory rate is like 40 times a minute, you're not going to get. Okay? And of course, open chest and abdomen, ARDS, less transmission of the pressures, use a threshold of 8. Okay? Abdominal hypertension, RV dysfunction, use a threshold of 15. It's okay. You don't have to be like D-dimer, it's just 1. Okay? But there are caveats. So what happens if your patient doesn't meet the criteria? And 31 out of 3 patients will meet the criteria to use an SPV. And if you have that conditions met, that's what you use. But what if the patient is not meeting my conditions? What do I do? What do I do? I can use, this is another thing that we have to correct. I'll tell you why. I can use the IVC change with respiration. When you are on the ventilator, it has to be the exact same criteria as the PPV and SPV. When you are on the ventilator, the distance signaling, I push air in, I push blood out. In a non-ventilated patient, I suck air in, I suck blood in. Okay? So, in the non-ventilated patient, it is a collapsibility index, but in a ventilated patient, you actually distend. okay? You distend. So when we are using IVC, because every time, why did you give fluid? The IVC was so and so. If you are using IVC on a ventilated patient, it has to be the same criteria as PPV and FPV. It's not a thing that happens with everything. Its main use, so again, less than 10%, unlikely fluid responsive. 12%, yeah, you're getting there. 15%, I'm getting there. 18%, I am very sure. Volume responses. And with the ventilator, it goes to about 0.84 AUC. In a non-ventilated patient, it's 0.77. I don't think the percentage should be there. But it is still better than CVP, which is sitting at 54, okay, 0.54. In a non-ventilated patient, if it is normal sized, collapsing about 50%, I don't know. If it is more than 2 centimeters and not collapsing, not fluid responsive. If it is less than 1.5 centimeter and collapsing 100%, you are fluid responsive. In between is in between. So fluid responsive, maybe fluid responsive, maybe fluid unresponsive, not a. Okay, we have seen that in the focus course. So even in the best of papers, you will be able to use these indices only in 80% of your patients. There will be 20% patients where nothing will work to tell you whether the patient is or is not fluid responsive. Is there a foolproof way? And again, the best way to determine if fluid bolus will increase cardiac output is to give fluid bolus and measure cardiac output, but that can harm. So there are other ways of giving a bolus without giving a bolus, reversible ways. One of them is end expiratory occlusion. Works in any situation, arrhythmia, whatever, because what you're doing is for 15 seconds, at least 12, for 15 seconds in a ventilated and sedated patient, you are doing end expiratory occlusion, and that gives you about 250 bolus, self-bolus, right? Because low pressure, increased venous return. You are getting a self-bolus. If I am ventilated, not sedated, and you do end expiratory occlusion, I'm coming after you, okay? Just making it clear. So the other way, so end expiratory occlusion will only be done if you can't do the passive leg raise test, okay? You can't do this if my leg is broken. You can't do this if I have increased intracerebral pressure. And when I do this, especially in awake patients, I tell them, I'm going to raise your leg and I don't want you to get startled. Because if their heart rate increases, what's happening, you know, especially if you have not covered their parts, right? And then they are like, shoot, okay, my ass is exposed. Heart rate goes up. Cardiac output is stroke volume into heart rate, false positive. Or I'm like, what's happening? What's happening? Okay, false negative. So you have to talk to them. Hey, I'm going to do this. The results are seen within 30 to 90 seconds. So you don't have to raise them up forever, but make sure that they are not doing abdominal exercises. You take the weight, okay? You take the weight. So from 30 to 45 degrees, while the nurse puts the head down, you put the leg up.
Just use the bed or?
You could, very good. In prone patients, you can't do leg raising. I guess you can, but you should not. Okay? You can do reverse, adrenaline. Yeah, absolutely, absolutely. It is variable. Some people will get 250 cc's, some people will get 350 cc's, somewhere around that way. And don't look at the blood pressure, you are looking at cardiac output, okay? Abdominal hypertension, severe abdominal hypertension, still remains the one thing that will occlude all of these tests, including the IVC and all that stuff. Okay? So, within 1 to 3 minutes, usually I've done this so much, I wait for 3 minutes because I don't go to the gym, this is my only workout. But usually within 90 seconds, you are going to see a change. And if you have somebody, hooked onto a arterial line monitor, arterial wave analysis, you are looking for a few things. An increase in pulse pressure, an increase in stroke volume, a decrease in pulse pressure variation, a decrease in stroke volume variation, or pulse counter, whatever the cardiac output was. If any of this changes 5%, why 5%? Because you are giving a very small bonus, okay? Or you can attach people to end-tidal CO2. And it doesn't matter what their heart rate and all that stuff is, okay? And if the end-tidal CO2 increases 5% or more than 2 points, and in anesthesia, you don't do leg raising, you do what you were saying, head down, right? It has been studied in these things, all of them have been studied in cardiothoracic ICUs, surgical ICUs, anesthesia patients, trauma patients, OR, outside. The indices don't lie if you know how to. And this is what I was talking about, that don't let the patient be agitated. And the best thing is, then you put them down and put their head up and see if it reverses. Because you gave them a bolus, cardiac output increased, put them back down, cardiac output decreased, confirmed. The AUC is 0.95, you won't get a better test on the bedside. In the critical care boards, they will ask you, do these dynamic indices help? And they will quote this study, Bednarczyk, 2017. Systematic review and meta-analysis, 13 trials, well-chosen trials. And it seems that if you use these indices to decide whom to give a bolus or not and how much to give, it seems that reduce mortality, reduce ICU length of stay, reduce duration of mechanical ventilation because you won't flood people with fluids. And it seems that there are indications that it does all that, okay? But we knew it from long time ago. And this study in 2020, basically, I use it to prove that if you use your head, you can assess fluid responsive status in 80% of your patients using one or the other or multiple indices. So everybody knows focus. What are we afraid of with fluids? That they will go on a ventilator? Before you see edema on chest X-ray, before you see edema on CT scan, you will see edema anterior T lines, especially in a patient who didn't have it before, okay? If they already had it, no. So, since I was a child, this is what I do. Patient should be in shock. My FPV and PPV doesn't matter. You don't just measure it on people and give them bonuses. What is shock? Urine output is decreasing, mental status decreasing, cold clammy skin, capillary refill more than 3 seconds, etc., etc. Blood pressure, pulse pressure, everything is dropping. If the MAP is less than 55 years, start Levophed peripheral, but don't stop there, okay? If it is yes, I start Levophed, that's not a problem. They can tolerate MAP of 55 for some time. If they are not there, I would, assess fluid responsiveness. If your examination and your assessment shows they are not fluid responsive, why would you give fluid? Just because you don't. But if they are fluid responsive, you give them a bolus. And then urine output picks up, skin turgor gets better, mental status gets better, Levophed turns off. Situation is resolved, you stop. If situation has not resolved, do a focus. RV distension, anterior V lines when not present, yes, stop. Why? Because they might still be fluid responsive, but what you have determined is that if you give them more fluid, you'll use less pressors, but you will get more mechanical ventilation. Both of them will keep you busy. I don't like being busy. But so no harm done, and situation has not resolved, you go back here and keep going on to that cycle until the patient is no longer fluid responsive, or the situation has resolved, or you are seeing, huh? Determination of volume responsiveness does not mean volume. You can't look at the IVC and say it's collapsible, so I'm going to give fluid. But it has to have a clinical context to it. That happens a lot in multiple ICUs.
Yeah, that happens a lot.
Lot.
Like you see patient is struggling to breathe because they're like hypertensive pulmonary edema and state renal disease. They're
Yeah.
not able to get dialysis and then someone sees the IVC being collapsing because they are in respiratory distress and then they get more fluid and then they go into more pulmonary edema and the cycle repeats.
It happens all the time.
Happens a
So
lot.
treat fluid like a medicine. You have to tell me why you are using, why did you choose that, why did you stop? And if you are using fluid because of any reason, you have to then follow up and see whether that fluid helped or not. Does
Another,
that make sense?
another experience that I had is patient is intubated, but he's not fully paralyzed, so he's actively breathing over the vent and his IVC looks very collapsible despite we gave fluid. That's again, another like.
Yeah,
red
breathing
flag.
ventilator is incredible.
Yeah.
They have to be, you have to, that's why do it early, because there's no use of doing this on day 2 or day 3. This is the first 6-hour stuff that we are talking about. Get them there. And then as they recover, just like in fact trial, we start taking the fluid off. That's all right. Okay. But nowhere does it say that you have to dry up a patient and they'll be better. The reality is there's no study that says that. Any questions, concerns?
Just a couple of comments. So, I'm old, right? So I would completely trash the CVP because actually, if the CVP is low or high, it actually does tell you something, right?
Yeah.
So the CVP is low, it tells you that number one, it's the right heart appears to be okay, right? Because otherwise the CVP would be high. It also suggests that the patient may be volume tolerant, right? If he's hypotensive, right? So just because the CVP is low doesn't necessarily mean he needs fluid. So if you think he needs fluid, he's likely to tolerate it. On the other hand, if the CVP is high, and when I say high, it's like 15 or 16, there's almost no situation where fluid will be beneficial because the right heart is already struggling and you already have a high pressure gradient to get fluid back to the right side of the heart, right? Because the CVP is already high. CVP is not necessarily, that's not a preload. Your preload is actually what's called your mean systemic filling pressure, right? Which is something else, right? CVP is what your mean systemic filling pressure has to push against to get volume back to the heart, right? Okay. That being said, you have to understand that the number that's on the monitor is a time average signal, right? And it's the waveform that matters, right? So you have to know what the waveform is supposed to look like and not just look at the number. Okay.
Yeah, one of the caveats in why CVP performs so badly is because most people don't know how to really measure it. Is it end expiration of, spontaneous ventilation? It's a difficult thing to do and it is still a static measure. The 50-50 is what, apart from the extremes, the reason we have got away from it is because in the normal patient, it's just not accurate. It won't tell you whether to give fluid or not. It will tell you what the CVP is and hope that it is equal to the RAP, which is equal to the RVEDP, which is equal to the LAP, which is equal to the LVEDP, and that represents volume. But here's the problem, okay? This is the problem theoretically. Let me see if I can draw this out. The problem is in a hypertrophic heart and a dilated heart, CVP low, volume high, CVP high, volume low. So the problem is that it tells you what the CVP high tells you is the CVP is high. And what the CVP low tells you, the CVP is low. But whenever you ask the question, what does it mean to give fluid bolus or not? When they have done those studies, they have come out, it's like a flip of a coin 50-50. In that case, just give fluid and see what happens. You'll be right 50% of the time, whether you use CVP or not. The problem is that CVP might tell you not to give the fluid when the patient is fluid responsive and tell you to give fluid when the patient is not fluid responsive. So therefore, we have sort of gone away from the static measurements. But yes, I guess in extremes, it is there. Can't use extremes for normal patients. Okay, normal IC patients. They're not normal. Anybody else? Good. So everybody can now tell me why they are giving fluid and when they are giving fluid, how much they are giving fluid. Good. All right.
So when did we get away from using the flow track as much as what we probably
I
should
have
with
no idea.
septic patients?
I have no idea because if you have a
We have
program available
access, yeah.
and you have an access, and Ronak is very good at giving access arterial lines and everybody. So then the question is, why not use the,
Curious.
just use it, just
Yeah.
put it on there.
How many machines do we have?
And we still have some, so the flow track itself is no longer supported, so when they break, they're done.
Yeah.
But we have still have the hemisphere.
The hemisphere.
The devices that can do the same
The
thing.
same thing.
So there's machines in CTICU and they have a conversion piece. I know it's one or two that we can convert over into the arterial line.
Oh, gotcha.
So,
And don't get me wrong, people have moved towards fluid conservatism. Overall, you'll see studies year after year, they use less fluids, but it is still better to use appropriate fluid on people who need it. Thank you.
Careful steward with everything. So again, we used to give way more.
Way more.
The difference between these studies now is everybody's given the same amount and nobody's given the gallons of fluid that we used to give, right? Literally gave people gallons, right? And we were using peeps of 50 at one point back in the 80s too. So,
Yeah, exactly. I think compare this to the 13 liters that we saw in Promise and all that stuff. It's 2 liters versus 4 liters, basically. That's where we have come up to. So the lines are meeting together and, should not be, and there's no difference. So now it was before, I guess. Okay.
studies